Welcome to our Implementation Science Seminar series this Friday for January. We are really thrilled to have you join. I'm Rachel Shelton. I help direct the Implementation Science Initiative along with Dr. Sapana Patel and Dr. Natalie Moyce. And want to thank them as well. And this seminar is also sponsored by the New York State Psychiatric Institute. And want to thank Dr. Milton Wainberg as well. And we have my puppy here as well, who's in attendance. So today I am really thrilled to have my colleague who's really been a leader in health equity and implementation science, Dr. Eva Woodward. Just to tell you a little bit about her, she's a clinical health psychologist and she uses implementation science to improve the equitable care and delivery for groups experiencing inequities, including communities of color, sexual minority groups, and low-income individuals. Her work has really focused a lot on implementing mental health and health psychology interventions in primary care settings. And she also complements her work with clinical care and training in primary care mental health integration. She's a trainer for Implementation Facilitation Training Hub, operated by the Behavioral Health Quality Enhancement Research Initiative through the VA, the Veterans Health Administration. And she currently works at the VA Center for Mental Health Care and Outcomes Research in Little Rock. And she's at the University of Arkansas for Medical Sciences. And we have really worked together closely this year. So I am so thrilled to have you all learn from her. And she's going to be talking about if you don't look for it, you probably will not find it, determining barriers to implementing equitably in healthcare settings.
Well, hey, everybody. I'm Dr. Eva Woodward. You can call me Eva, like whatever. As Rachel mentioned, I am a clinician also. And I actually had to usually that's on Mondays, but I'm a mental health clinician, so sometimes suicide risk comes up and those things are urgent. So I actually just was running from a clinical urgency to here. So something that I am going to do with us just to make sure we're all kind of centered here, because I'm sure you're also coming from things, it's just a really quick 2-minute kind of check-in. Just a quick mindful breathing exercise, giving you the real clinical psychologist experience. And just to be here, you all are choosing to spend your lunch hour with me, which is so precious. And so if you'll join me, you can close your eyes or not. Just breathing as you normally would. Noticing where you feel your breath coming in, maybe your nose, throat, chest. Noticing where you feel your breath coming out. Just inhaling, noticing when you're inhaling, noticing when you're exhaling. And checking in with where you've been before now, what you've been doing, what you've been feeling. And now asking yourself what you're going to do for the next 50 minutes, what you're here for. And what can you leave behind? Taking one more breath mindfully in and out. Okay. Kind of come back, open your eyes if they were closed. Thank you, whether you did that or not. Thank you for at least giving me the space to do it and really be right here with you all at Columbia and the New York State Psychiatric Institute. Okay, So the topic at hand, I did not change the title. If you don't look for it, you probably will not find it. Okay, Rachel, can you give me a thumbs up you're seeing the correct presentation? Okay, I'm going to talk about determining barriers to equitable implementation in healthcare settings. Now, what I'm going to talk to you about is, and the work I've done is all in healthcare settings, hospitals and clinics, but it certainly needs to be done in community settings, school settings, and you can apply it to that. So there's my Twitter handle if you want to follow along. I am in sunny Little Rock, Arkansas, and I like living here. I used to live in the New England with y'all, and very cold, too cold for me. Okay, some acknowledgement. Some of the work I'm going to talk about was funded by the VA Office of Health Equity. I'm a fellow with the Implementation Research Institute, funded by WashU, and I have a VA Career Development Award, which is like a K. Also, my views here don't reflect the US government. So I know we're all coming from different backgrounds and perspectives, so I'm just going to talk about definitions as I see them, even though I know these are controversial, actually. So health differences are just differences in health outcome, diabetes, cancer, depression, suicide, between two groups based on a specific characteristic, height, race, income. It's a health disparity if it is concerned with social justice. If, in fact, the group that is having the worst health outcome has experienced a social injustice, marginalization, oppression that has indirectly or directly contributed to that worse health outcome. And so we want to reduce health disparities in order to pursue health equity. Health equity is the goal. It's a principle underlying a commitment to reduce and ultimately eliminate disparities in health and its determinants. So health equity is when everyone has a fair chance at living well and having good health. And fair doesn't mean giving everyone the same thing. So equality is giving everyone the same thing. If you see the top visual here, we have people with different physical needs who all are given the same bike. The person with the wheelchair can't even get on the bike. The really tall person is hunched over. The person in the middle is like, I'm good, this is good for me. Everybody got the same thing, I'm good. And you see the kid who's barely making it on this bike that's really for adults. But equity is the image at the bottom. What if we tailor what we give to people based on their needs? So now the person who uses a wheelchair has an adapted bike and is able to use it. The very tall person has a bike that's taller and fits them better, etc. So in implementation science, where we see health disparities is when there are significant differences in access to some type of innovation, some type of intervention, or differential rates of receipt of that thing, or when there is a significant difference in the quality of that thing, that innovation, that intervention, whether it's a therapy or a pill, or maybe it's a good practice like hand washing or flossing. Perhaps in delivering that thing, the quality of care is different, and that those differences are between two groups are likely attributable to some type of social injustice. So some people call that healthcare disparities. So that's the kind of stuff that I'm interested in, and that's the kind of stuff that we want to reduce and eliminate. And there are lots and lots of ways to reduce healthcare disparities. And I'm only going to propose one that's even only from a research perspective. So just know what I'm presenting to you is not the end all be all. It's just one of many parts of this pie. The current textbook, if you will, on implementation science is this blue book here, Dissemination and Implementation Research in Health. And there's a chapter, 27, on dissemination and implementation research among racial and ethnic minority and other vulnerable populations. because disparities is always chapter 27. It's always an afterthought. So it is fortunately the forethought of this talk, but in that talk, the chapter authors, including the late Dr. Yancey, said implementation frameworks as they are might be modified for application among specific racial and ethnic minority and other vulnerable groups. So there are several types of implementation frameworks that exist out there, and they were saying, you know, they've probably been developed for equality. They've probably been developed for the general population. So they might need to be modified for equity. And so that's what I did, and I'm going to present to you today. Quick foundation here. There's 3 types of implementation science frameworks. Determinant frameworks. These help us ask, what are the barriers here and why are they here to implementing something? A process or planning framework. This is frameworks that help us try to plan out, how is this thing going to get implemented? And how are we going to do it equitably? And then there are evaluation frameworks, which help us actually select our outcomes and design evaluation plans and ask, did this implementation succeed or fail? And is it equitable or not? The kind I'm going to talk to you about today is a determinant framework. So it's focused just on this question of what are the barriers here and why? It's focused on, if you're a clinician, it's focused on diagnostic assessment. You wouldn't offer a treatment to a patient if you had no idea what the diagnosis was. So that's the same thing in implementation. We don't want to go in, you know, to a healthcare disparity and be like, these people need X, Y, and Z, if we haven't really done our homework to understand why the problem exists and why it's specifically inequitable. So what happened was, out of need, I needed to, in some of my work 4 or 5 years ago, adapt an implementation determinant framework to be matched for a health equity problem, a healthcare disparity problem that I was investigating. So I took IPARIS, Integrated Promoting Action on Research Implementation and Health Services Framework, getting your mouth full. This is mostly out of the nursing literature and the nursing world. This is an implementation determinant framework that proposes barriers to implementation. But what it was missing, and what all the implementation determinant frameworks were missing, was a focus on things that health disparities researchers know actually predict health and healthcare disparities. So I took also the domains from the healthcare disparities framework, published by Kilborn and colleagues, that actually accounted for some of those. I merged them together. I also did some literature searching of seminal health disparities text. You know, I had the textbook by Thomas LeVice. I was scanning all the things. I had my manila folder, all the stuff, and tried to see, okay, what are really common domains from healthcare and health disparities research that we already know have entire bodies of science behind them saying, these are things that predict disparities in health and healthcare. And I narrowed it down to 3. And I added those domains to IPARIS. So I adapted an existing implementation determinant framework with 3 health equity domains. And I call it the Health Equity Implementation Framework. I'll share it with you now. We're going to start small and build out. First, you've got the innovation. This is what I referred earlier to as the thing. This is the thing you want people to start doing. Again, your pill, your practice, your policy, perhaps. And there's lots of factors that you care about in the innovation. 2 examples here are, does it have a relative advantage over other things that are trying to be implemented for this problem? What's the degree of fit it has with the existing practice? And then there are recipient factors, and recipients are many groups. It's basically any person that's going to be asked to do something differently here. So at the top, you've got patients. At the bottom, in healthcare, you've got providers, but in schools, you know, it might be teachers. And then you've got other recipients, like other staff they meet along the way, informational desk folks, nursing staff, for example, people in the lab. So each of that will be different based on your setting and your problem. But the star is here because this is one of the domains I adapted. It already had basic factors about each of these recipient groups, but what it didn't have was an explicit attention to cultural factors, meaning what are the cultural norms these people are living in and believing based on their lived experience. So things like, for patients at the top, beliefs and preferences, their culture and community, their health literacy, perhaps a biological need. And for providers, some of the cultural factors are, what are their knowledge and attitudes that might be special to this disease state? What are their competing demands? You know, they've got 20 other patients to see today, or they need to meet this type of quota, or they need to do it in this way versus this way. And also, what bias are they bringing to the table? Significant amount of literature shows that providers, myself included, maybe some of you in the audience, carry around with us a bunch of bias we aren't even aware of, and some we are, toward many, many groups. Groups who are not straight, gay, bi, queer people, people who present as fat or overweight in healthcare appointments, certainly racist bias against people of color. So how is that affecting implementation? And then you've got all of those same factors for other recipients who have their own knowledge, motivation, and skills or power to enhance equity, or perhaps they're limited in knowledge, motivation, skills, or power. So the second addition that I made to this framework was actually attending to the clinical encounter. This is the moment when that patient and provider interact, and there's the opportunity for the provider to offer something and the opportunity for a patient to say yes or no. And also, entire bodies of research on patient-provider interactions showcase that what happens in that moment predicts patient satisfaction, trust, patient health behavior, and patient health outcomes. So it makes sense that in implementation in healthcare settings, we're looking at what's happening there. And again, that's an opportunity for everything to go right or everything to go wrong. And then all these people and these things are embedded in a context. So in a healthcare setting, you've got on the right, you've got the inner local level, you know, that particular clinic or service or ward. And then you've got the inner organizational level, you know, broadening out maybe to the service or the department. And then you've got the outer context, factors in the healthcare system itself. Maybe it's the hospital, maybe it's a network of regional hospitals, perhaps. And even though I didn't star this and add anything unique, certainly equity is important at all these levels. You know, at these levels, is leadership supportive of implementing something or not? And are they supportive or even aware of a healthcare disparity problem? Do they have experience trying to reduce healthcare disparities in their settings already, or do they not? So that, in addition to that focus on disparities, in addition to just the regular things we care about in implementation, are important and affect each level. You know, like, what is the culture and climate of change here? What's their readiness to actually make this kind of change we're asking them to make? But then with the health equity lens, it's even an additional set of questions that you're interested in asking. And all of this in the healthcare system and the people and the thing are embedded in the societal context. So this was the third domain that I added, which is a very broad upstream domain that involves social determinants of health, if you're familiar with that, but it also involves things beyond social determinants of health, like economies, economic factors. How are goods exchanged here? How is healthcare received here? Insurance. Also physical structures. Other words for this, built environment. So how does what the patient is exposed to at home affect the implementation of this? How does what they have to experience in their physical environment to get to this healthcare, how does that affect implementation of your thing, your innovation? Once they get to the point of care, how is what's going on, the signage that they see, is it in the language they know? Is it translated well? Is there privacy when there needs to be privacy? Are there faces that look like them? Are those physical structures present, and are they hindering or helping healthcare disparity problems? And then socio-political forces. These are social norms, things like racism, transphobia. This might be a stigma against a certain medical condition, like HIV or drug use. And these are also political forces. So policies, small policies could be at the hospital level, saying, you know, we don't provide or pay for this kind of care for these kinds of people. It could be a big P policy, state level, federal level policy that affects healthcare in some way. So it could be, for example, in the US military, in the last presidential administration, saying, you know, we're going back to a don't ask, don't tell for transgender service members, and how that affects downstream. They're implementing a healthcare intervention for them. This could also be laws. I worked on a project facilitating the uptake of an HIV intervention in Jamaica. And in Jamaica, it's illegal to engage in same-sex behavior, as it is in several countries in the world. It's criminalized. And same-sex behavior is the biggest driver of HIV in that country. So that seriously is an important consideration as we had to, when we were assessing what are our barriers to implementing this HIV intervention equitably here for the people who really need it. And our implementation plan changed because of knowing that law. So this these are all the domains where you could have different determinants that are helping or hindering implementation. And hopefully, once you get done assessing, you'll add a process to overcome or work around those barriers. And that might be facilitation or other implementation strategies. And the hope is that it will lead to implementation success and improvements in health equity. And again, each of this will vary by your particular health condition, population, and setting. Just to recap, the take-home point is assess 3 health equity determinants in any implementation effort, especially if you know that there's a healthcare disparity there. The cultural factors of the recipients, those patients, providers, staff, the clinical encounter, the moment at which they interact and you want the thing to be offered and then accepted, and the societal context, economic factors, social norms, policies, laws, physical structures, and other social determinants of health. So here's some examples of how you might assess those things. Now, if you are simply doing implementation practice, you're facilitating, you're the practitioner on the ground, you can do this informally or formally. As researchers, we tend to do it more formally. There's options here. I've done both because I do work as a researcher and I also work as a practitioner actually getting programs up and running on the ground. So you've got the determinant on the left here, and here's just some sample methods and measures. This is not exhaustive. It's just a little snapshot for you here on a slide. Get the juices flowing. Societal context. So that's the economies, the physical structures, the socio-political forces, and other social determinants of health. You might look at insurance claims data. How are most patients paying for healthcare here? Or are they? You may do some observation, ethnographic observation or walking observation of physical structures. You might, for my friends in public health, you might do a windshield survey. You might review documents of organizational policies, maybe current or past, to understand some of those factors better. You might actually administer measures like the state level racism index to actually determine something about the state, the city, the neighborhood in which you're trying to implement this thing. And then you also can look at tons of social determinants of health. And I recommend what NIH has put forward, which is the PHENIX toolkit, which is a recommendation of many measures, kind of synthesizing together standard measures for various social determinants at that website. The other determinant you have here is the cultural factors of recipients. So again, examples of specific determinants within that might be, is there a demographic match between the patient and provider? Because we actually know that's important. Like, is a woman identified patient getting a woman identified provider? Is a Black identified patient getting a Black identified provider? What is provider bias? What is patient mistrust? What's the patient health literacy? And there's many, many more cultural factors that you could think of. Some I'm sure I have not thought of. And some sample methods or measures for those are, what if you do chart reviews to calculate how often there was a demographic match between patient and provider? What if you administered the implicit association test to tap unconscious bias among providers and staff, or patients, depending on the problem? Asking patients to do the medical mistrust index to assess their level of medical trust or mistrust. Again, there's health literacy scales on the Phoenix Toolkit. You can actually do individual interviews to really capture some of this information qualitatively. And here is some sample methods and measures for the clinical encounter. This requires a special set of skills, audio recording encounters. So you're actually recording what's going on and analyzing it. Conversational analysis is even more specific. You might actually observe a sample of encounters. You might actually interview patients and providers before, after, or after to debrief on how it went, what they think happened. And you might use chart reviews in a medical setting to actually review, or some type of documentation of the encounter. So there's lots of ways to measure it, and it just depends on your resources, your problems, what you have going on. So here, I'm about to share with you an example of when I have used this framework in my work. So this is about Black veteran perspectives on barriers to and facilitators of implementing hepatitis C virus treatment in the US South. So of note, this was also the first pilot of the health equity implementation framework. I piloted this in here before I even gave it that name. This was where it was born out of need. So I have been asked to investigate patient-level perspectives. Now, again, we're missing a whole bunch of other perspectives here, which you would ideally want. But other VA researchers were getting the providers, the leadership, the congressional perspectives, and I was tasked with patient perspectives. Specifically among Black VA patients who had hepatitis C, because the VA identified that they had a healthcare disparity. So just in case you know, I wish there's a lot of technology going on here. I can't get back to the chat. Okay, well, if there's a hepatologist in the room, we can chat about this more. You know about this. So hepatitis C virus treatment was really bad. There was basically not treatment. It was interferon, which was like didn't cure it that well or often, and really a lot of side effects, and people had to be on it for a long time. It was awful. And in 2015, hepatitis C virus treatment got revolutionized. The FDA released a pill that many, many people could take for 3 months and cure hepatitis C over 90%. Serious relative advantage. And what they found is that they rolled it out in the VA, and Congress even approved like $500 million to make sure it was offered free of charge to veterans. And they were finding that there was a disparity in the receipt of this treatment by race, such that Black veterans were not receiving it at equitable rates compared to white veterans. And that is especially that's a problem on its own, but it's especially problematic because there's also a health disparity in the prevalence of hepatitis C in this condition. So in the United States, Black and African American folks are more likely to have hepatitis C than white folks. And so then that means they should be getting the treatment more treatment should be going to them. And so the VA was worried about this and put a lot of people on the case to assess what is going on here. So that's what my team and I did from the patient perspective. So and just to let you know, when I say HCV, that's hepatitis C virus. So we interviewed a small subset of people, 12 people, and there's a lot of information on here. But I want to draw your attention. These were VA patients who actually 67% of them had heard about the treatment before, and 42% had actually started or completed it. So there were still more than half that hadn't. So these were all of these people were cisgender men. They all identified as straight or heterosexual, and they all identified as Black or African American. And we interviewed them in fall of 2016 for via telephone. And we asked them basic information about hepatitis C virus treatment, what they knew, their understanding. And then we asked them barriers and facilitators in a qualitative interview aligned to domains of what would become the health equity implementation framework. We asked about the innovation itself, providers, their own personal preferences and cultural norms. We asked about their local VA clinic, the VA at large, and then societal factors at large. That's what we were calling it then. And we specifically asked about potential racial discrimination. So I'm going to show you the results visually. This is the health equity implementation framework. I'm going to show you what they told us. Let's start with barriers. So these were people that either had gotten care and we're talking about what their barriers were, or these were people who hadn't, but they had tested positive for hepatitis C virus treatment and hadn't started treatment. So that tells you there's a problem. And so these are the barriers to implementing that from their perspective at all of these levels. First, they felt that the innovation needed a medication reminder system, like blister packaging, where the pills, you punch out the pills you're supposed to take every day so you know, oh, I've taken my pills today. Recipient factors that are more cultural factors is that some people didn't know about what hepatitis C virus symptoms were, and they either did not trust their providers or they had this kind of submissive trust, what my team ended up calling it. And this is something I experience regularly as a healthcare provider. This like very blanket trust, like, well, I just do what my doctor tells me. Absolutely uncritical of their providers and their healthcare providers at all. And so they just did absolutely everything a healthcare provider told them. Or if they didn't mention something, they trusted that they didn't need it. And provider factors that the patients perceived were that they perceived that some providers were racist. And they also felt that some of them did not have the knowledge, the special knowledge about this treatment, which is probably true. Both those are true. And in the clinical encounter, we went into this a lot. And they ended up talking about it was really negative for them when providers did not offer any treatment or explain a rationale for the decision to treat or not treat, or they didn't offer any follow-up. So it's a bad experience as a patient to test positive for something and then get no care. Not surprising. At the organizational level, there was a lack of follow-up after testing positive that I mentioned, and there wasn't enough treatment for Hep C at their local clinics, which was an issue. They'd have to go to a bigger medical facility somewhere in a different town. Now, a physical structure problem is that almost all these veterans were living in rural places in the South. So they had a lot of transportation barriers to even get to the rural clinic that might not have the treatment. So it was especially hard to get to the bigger hospitals that did have it. An outer healthcare system factor problem was that there were testimonials for them from their friends or family about racial discrimination they had experienced at that VA or VA nearby that made them not want to go get care. And they also had negative VA experiences generally. Some of them had. So if they'd had a bad experience with anything else, they didn't want to go there for anything. And a socio-political force factor was that there wasn't enough hepatitis C material circulating, especially in rural areas. They really felt like there was not a lot of discussion about what hepatitis C is, how you get it, where they lived. And there's a lot of stigma about how you get hepatitis C virus treatment. Did you get this from using drugs? Did you get this from having sex with a lot of unprotected sex? Like a lot of that stigma in society that they experienced. So those were all barriers from the patient perspective to getting hepatitis C virus treatment for Black veterans. Here are the facilitators, the good things. First of all, I'm going to start off with the economic factor, free treatment. Nobody complained about cost. And that's a beautiful thing about doing research in the VA, is we can actually control for one of those factors, or rather it's kept level. You know, most people are getting care at no cost or low cost. The innovation, they felt that the regimen and the cost of it, of course, was acceptable. And they didn't need the ability to trial it. They didn't need to try it beforehand. They're like, nope, this works, I'm taking this, or I'm interested in this. Patient factors, especially ones related to their own culture, was that some facilitators were that they hoped there was no racism in the VA. They hoped they wouldn't be discriminated against. They really wanted that to believe that. And they were really optimistic about treatment. They wanted a lot more education about the health condition, and they had a lot of positive trust in their providers. So again, this is not everyone. And again, different patients felt differently based on different providers. So it's not like there's people in one camp or people in the other. You know, it's different. Provider cultural factors they perceived is that some people perceived that their providers really did have a desire to help them. And some Black veterans we interviewed did feel that different providers had lower levels of racial bias, which was a big important thing for them. The clinical encounter was positive when providers explained treatment, explained side effects, clarified next steps, and answered questions. Another good thing is that once they were offered treatment, many people did not wait very long for an appointment. A healthcare system factor is that a lot of veterans felt like the VA uses the best medicine, they use the best treatment. I believe that. And they want to help us. So there's a belief about the VA at large that was positive from some people. And remember, one of the societal forces that was a barrier was the stigma towards hepatitis C virus treatment. One of the offsets that veterans mentioned is that the way the VA did business really protected their confidentiality, and it offset some of that stigma. So, and if you've worked in a VA, you know, like, we are on lockdown on security. It is excessive. I've worked outside the VA, and there's, of course, HIPAA and things you do to protect patients everywhere. But in the VA, it's like double down. And so they never felt that their information was going to be released. When they went to clinics, they talked about, they were never identified as like hepatitis C clinic and come to this waiting room. And so they actually felt that those measures in the physical structures and in the healthcare system at large, you know, really offset some of the stigma, that they felt stigmatized still, but they knew it could be private. So that facilitated them going and keep going back. And some socio-political forces was that they actually, some people had the opposite. They had positive testimonial from peers about who had gotten the treatment. Oh, my brother, my cousin, my neighbor has gotten the Hep C treatment, and he's feeling so much better, and I'm more inclined to do this. And about healthcare in general. You know, yes, my family's always like, go to the doctor, go to the doctor. And some people had been exposed to written materials about hepatitis C. So they had some sense of like, okay, I get what this is, and I need to get this treatment, and it's out there. So this is just one example of how my team used the health equity implementation framework to design our qualitative interview guides. And then I didn't get into all the analysis, but we also analyzed it by domain. Now, we had a couple of themes we identified that were not in the framework that we then incorporated into the framework. So this is like version like 3.0, what you're looking at right now. It helped, and I went back to literature on topics like on structural competency and structural violence, and started to actually see, oh, there's a lot of these other domains that some of these participants are talking about. So we used it to refine the health equity implementation framework here, and then got a lot more consultation from other experts in either health disparities research or implementation science. And so that's what has led to it today. Now, again, you can do mixed methods assessment in each of these domains, you know, doing observations, doing interviews, document review, quantitative surveys. There's lots of ways you can go about this. It's very, very open. And my team has a current paper under review for a more practical guide that offers some suggestions for that. Overall, the point is, when you're trying to assess why an implementation problem is there, and you have a suspicion or you know there's a healthcare disparity, if you don't look for it, if you don't look for the reasons why that disparity is there, you probably will not find it. And if you don't find it, are you going to plan for it? Probably not. So now you're going to have implementation plans that are going to hit, you know, strategies and plans that are going to hit certain areas, but miss huge drivers of healthcare disparities. If you, you know, in this case, if you've got nothing in there that's going to try to address racist bias among providers and historical racism from the VA and hepatitis C virus stigma, you're missing a huge thing. And I'm very happy to report actually that the VA took my data and a bunch of the other researchers working on this, and they created this incredible comprehensive VA national Hep C implementation plan that then they rolled out, and the VA has treated almost every veteran for hepatitis C virus treatment. I think we have like 30,000 veterans who have hepatitis C virus that have not been treated in the VA, and the racial disparity was reduced significantly. So that's the good news. Your work matters. The very last thing I'll say to y'all, because we're in the season, I can't help but give a plug. If you want to come work with us in Little Rock, Arkansas, we've got an implementation science postdoc. I'm not trying to poach y'all. But if you are out there, you have to have a clinician degree because it's split. 75% research. We focus on telehealth care in lots of conditions. We focus on mental health, suicide prevention, trauma, and we have a big focus on rural dwelling people. And you can contact either of these two people there or me, and we'd love to have you come work with us. Thank you for listening. Now, let's get into the meaty discussion.
Thank you so much, Eva. That was really amazing. Your communication about it is so clear and helpful. I learned so much.
Oh, thank you.
So I have muted people so that they can ask questions, but I see that there are already a couple questions in the chat. So I can go ahead and read that. I'm not sure if you can see it, but
I can see it.
Oh, okay, perfect. Great.
So someone's bringing up a question that says the IAT, the implicit association test, that is one possibility to assess unconscious bias, has seen its share of controversy. Yes, thank you for highlighting that. Is there another implicit bias measure you've used or had a good experience with? I have not had a good experience. I should say I haven't used another. Now, let's open that up in the chat for people to type in other things you all might know of, because we need to generate our knowledge collectively here. Okay, so someone else said the framework is used to elicit barrier information from patients. That was my example. And I assume also from providers. To what extent is that information overlapping? That's a great question. In an ideal world, if you are, whatever setting you're implementing in, you would want to use this framework or some framework to guide your assessment, and you would want to sample any of the key stakeholder groups that are affected by it or would be charged with doing something differently in your implementation plan. So again, in that example I presented to you, I only looked at patients because that was my only task on that larger team. But again, you're definitely tapping in, and again, I'll just take it to that healthcare example. We want to talk to the providers, the nursing staff. We want to talk to leadership. And they did assess congressional viewpoints on the topic and like cabinet level administration. And to what extent is that information overlapping? It's fascinating how much it doesn't overlap. That's my personal experience. Now, occasionally it will overlap, but the motivations behind doing something are so different between patients and providers sometimes, or leadership. So I see it rather as getting different perspectives, possibly on the same topic, and also getting different needs for the same topic. The funder is like, all right, I'm good with giving this therapy, medicine, whatever, but I need it to be cheap, or I need to have a good return on investment. And the providers are like, fine, but I need it to be condensed in a reasonable time period in my schedule. And the patients are like, I just want it. And by the way, I want you to mail it to me. I don't want to have to come in. So could we then adapt the innovation to meet those needs? Or could we also adapt our implementation plan and strategies? So my experience is that there is some overlap, but that it is very necessary to sample all the different stakeholder groups. And again, with schools, these are going to be different stakeholder groups. With your community settings, they're going to be different groups.
Thank you.
Other questions? Yeah. And I'm also would love discussion. You know, if someone else is like disagrees or has important additional thoughts, unmute yourself or type.
I have a question about, you chose I-Paris in your work. Is that, I don't even know if I said it right. Is that right? I don't know how to say it. I'll be honest.
It's I-Paris, but I love that you did a little en français.
A little French. Is the model that you used here, is that intended to be one example of many implementation determinant frameworks you could use to apply it? I'm thinking through like if people use CIFR or other ones.
Yes. Just had this question on the call with somebody yesterday. This is my take on it at this point. And I'm very open to critique. We are building this ship as we are flying it, people. So teamwork is what we need. I am proposing that people either use the health equity implementation framework as a whole and call that good for your determinant framework, or take those 3 domains and adapt any other determinant framework you already use, you already like, you're familiar with. So I just advised somebody yesterday who's like, I want to use the health equity implementation framework and CIFR. And I'm like, you're going to have so much redundancy because all of the implementation domains I-Paris has, CIFR has too. And so I encourage them to take those 3 domains and add it to CIFR. And to my knowledge, that would be the first adaptation of CIFR to a healthcare disparity problem. So if it is a determinant framework, just add those 3 health equity domains and see what happens. And again, refine it and get back with me, see what happens, what changes. Are there any thoughts on that?
So you mean within those levels? Because I imagine there's some overlap, right? Between like the patient characteristics and the clinic, the clinical characteristics.
Right. Because like CIFR, for example, has a patient, like a people domain. And I would say, okay, be explicit about assessing whoever those people are that are involved, those recipients, be explicit about assessing some of their lived experience and thus cultural factors related to this issue. Yes, you'd have to be thoughtful. You'd have to really sit down and think like these 3 domains, how do I subsume them under certain domains in another framework, or are they totally separate things? Like the societal influences, or the societal context domain, I think gets tapped a tiny bit in CIFR, but it's not super explicit. And that's the whole point. That's my point, at least, is how often in any initiative, even outside research, do we say, okay, this general thing should also account for special populations? This thing that's made for general populations, yeah, you can assess disparities in here, you can intervene on them, but when it's not explicit, it doesn't actually tend to get attended to. Again, if you are not actually looking for barriers related to inequitable implementation, you're probably not going to find them. People aren't just going to be coming out of the woodworks like, just to let you know, people are really racist here. So that's not what happens. And as a person who's been on the ground implementing things, that's not what happens. Unless you ask for it, you will not find it. And even if you do ask for it, sometimes you will still not find it. So you have to find other ways to get that data.
And how much do you think that assessment has to be qualitative, open-ended versus starting with more, starting with some of the assumptions or some of the lessons learned in terms of the constructs you presented? Is it a mix of that, or should it always be that open-ended qualitative?
I think it depends on your purpose. Again, if you are a practitioner, you are like standing up new initiatives, you are doing quality improvement on the ground. I just think you're not going to have as much capacity to be administering surveys and stuff. I do that almost exclusively qualitatively as a practitioner, although I am going to start using some quantitative surveys, and that people do that. But as a researcher, I think it depends on your problem. There's probably in your health area, in your population, there's probably already some established data on like, these are drivers of healthcare disparities. Like health literacy is a huge problem with this, or stigma is huge for this group. So we should definitely be assessing that. My take is to start there. Or something, that you might hypothesize that you're not sure about. What do y'all think about that? That's my approach. I'm like, do what is informed already by existing literature, start there, and also do what you know how to do, and or pull people in who don't. If you don't know how to do observational stuff, ethnographic stuff, get somebody who can, but maybe you can't.
That's helpful. Thank you. Yeah, I agree. We tend to kind of like try to recreate the wheel when we don't need to necessarily, and there tends to be already experts in areas or large literatures that relate to that. So I appreciate that.
Yeah.
Any other questions? We have about 7 minutes with this amazing expert. So please, if you want to ask any questions in the chat or unmute yourself, please do.
Hi, Eva, it's Sapana. I just want to thank you for an awesome presentation. And I just want to say that I really appreciate that you laid out some of the methods that you used per each level of domain in terms of assessment, because I think that's really key practical information that oftentimes when we're introduced to a new framework or some way or some heuristic of looking at equity or implementation, we're kind of at a loss of how to measure and how to assess. So I really appreciated that. I wanted to ask if, you'd made a comment about disparity reduction after the VA rolled out, a sort of system-wide implementation based on some of the lessons learned. When you guys were looking, and I know you specifically looked at the patient level within this effort. So I'm wondering, when you guys, as you guys were rolling this out and you did find that there were reductions in disparities, what kind of patient level outcomes were considered or thought about with respect to disparity reduction? Like what would you recommend in terms of impact that people measure? Because I think there's the process piece, but I think the outcome piece is an important one too.
Yes. And ultimately, that's the end game. Like, if we're not, like, I'm like, I can use a really thoughtful framework, and if I'm not changing anything, like, I'm clearly still missing something. I'm not doing it right. So I totally hear you on that. Outcomes is really important. Well, I will give someone else on this call a little plug with this, is that your very own Rachel Shelton has published some on this, which I really love. Actually reading, Rachel, can you go get that link to the REAIM paper, please? Because I'm like, I've got all my presentation and my monitors. I'm overwhelmed with technology. So she and other folks published, using REAIM, which is for other folks is a common implementation evaluation framework, and she suggested, how could we embed a focus on equity here? And I really liked it. It's one of the only things out there that I read that was, again, specific, like you're saying, Sapana. It got really practical, and it really inspired me. So things like even reach, for example, like instead of just saying, like, I'm reaching people with this health condition, why don't you even describe the descriptive stats, like who's being reached? If you find out you do all this implementation stuff to reduce Hep C among Black folks, and you realize the minority of Black folks are actually the minority of people you're serving with this implementation effort, that's a problem. So that's an example. In terms of outcome measuring, this is not my strength, just because I'm not trained like that. And there is, I wish I had all my stuff with me. There's a really good recent paper, Rachel, help me if we can, that just came out that someone talked about when it's like been in the last 3 months, when you're reporting on race, do these things. Was it Ray Boyd?
Oh yeah, Rhea Boyd and Monica McClurmore. I can send it. And I also just
Thank
sent
you.
Leo
Thank
and
you.
Anna's paper that also talks about that as well. I'll send that right now.
Okay. Yes. So, I mean, and again, Sapana, I think it really depends on like, what do you care about moving the needle on? Measure that. And again, that's going to differ by health condition and patient group. One thing I want to share with y'all is, Apana, to your point about the measures and getting practical, I told you that my lab has under review a more practical guide. And by the way, for people on this call, if you do want to take a qualitative approach, I have a qualitative code book and a qualitative interview guide questions. Again, you can play with them and mess with them, but I've got those. So please feel free there to circulate and use.
Great. That's
one of the things we did in this paper, and again, I'm happy to circulate it now, is we have actually compiled a more comprehensive, again, it's not totally comprehensive, of course, but table of measures for each domain.
Eva, I'll connect with you, and I think people would be really interested in that qualitative interview guide and code book. So maybe I'll get that from you, and then I'll circulate it to the people who are on this call today.
Okay.
That would be
okay. That sounds great.
Great. Well, I realize we are at the hour, so I just want to give a huge round of applause to Eva for this amazing presentation. All this information, it was so helpful. It was recorded, so we will be able to post that and share. And I just want to thank you all for joining us, and I hope everyone has a wonderful weekend. We'll see you soon. Thanks, Eva.
Happy Friday. Thanks for having me all. Take care.